Welcome back to Soundbites Ultrasound, focusing on part 2 of OBGYN ultrasound, the ultrasound of the adnexa. To lead into our discussion of adnexal ultrasonography, let's review the anatomy of the OBGYN structures. We see the uterus to the left and the adnexal structures well seen here to the right. Notice the portions of the fallopian tube, the isthmal region, the intermediate ampullary, and the distal infundibular region. We see the ovary here, just distal to the infundibular region of the fallopian tube, encased in the broad ligament. Now the ovary can be relatively mobile in relation to the uterus, and thus we may have to search either anterior-posterior to the uterus or in a vertical manner, up or down, to best visualize the ovary. For this examination, it's best to use a transvaginal technique to best see the adnexal structures, and so we're going to need an endocavitary probe. We see a typical endocavitary probe as shown here. Notice that it has a slight bend in it, and on the top of it is going to be the probe marker that will align us to the indicator dot on the screen. Ultrasound of the adnexa is considered an advanced technique for the emergency physician, as it's more difficult than routine investigation of the uterus. We'll need to employ the transvaginal approach, as the adnexa are difficult to visualize on routine transabdominal scanning. Now, it's very important to empty the bladder prior to examination to best optimize our odds of finding the ovary and the adnexal structures. As a first step, we're going to fully visualize the uterus in both long and then in short axis orientations as covered in Module Part 1 of OBGYN ultrasound. So the second step is then to aim the endocavitary probe laterally while in short axis orientation, and then visualize the ovaries by moving the probe up and down in a vertical axis to best find the ovaries. Now the ovaries can be either anterior or posterior to the uterus, and this vertical movement of the probe will best illuminate the ovaries. Once the ovary has been fully investigated in the short axis configuration, the third step is to swivel the probe on the ovary, so now that you're in the long axis plane with the probe marker up towards the ceiling. That allows you to scan through the ovary in a second configuration to fully assess the correct dimensions of the ovary so as not to underestimate the size. It's important to look in two axes to fully get the sense of how big the ovary is. Now let's discuss the specific techniques that are used for examination of the adnexa. We note here a typical endocavitary probe to the upper right. Note the marker is the notch on the top of the probe, and note the endocavitary probe has a slight curve away from the marker. Let's look at the picture to the bottom right, and we see here an ovary with multiple cysts. Note the screen indicator, that small white circle here towards the left of the screen. Now, if I was in a short axis configuration, the marker dot on the endocavitary probe would line up with the indicator dot on the screen. And if the marker was to the right, thus the indicator there would show the right side of the patient. This is a way of figuring out where you are spatially with regard to performing ultrasound. Now, there's two possible techniques for visualizing both of the ovaries, and they're determined by the relation of the probe marker to the right and the left adnexa. In general, we'll want to start in that short axis configuration, but we want to remember that the probe marker is going to correspond spatially to the screen indicator, and thus it's going to measure up so that movements with the probe will be aligned with movements on the screen. The two techniques I'd like to go over are the flip technique versus the swing technique, and we'll go through these in some upcoming slides. Let's begin by discussing the flip technique for ultrasound of the adnexa. Step number 1 is to move the probe into a short axis configuration, first identifying the uterus. We'll have the probe marker positioned towards the patient's right. We'll then aim the probe into the left fornicele area adjacent to the cervix to visualize the left ovary and also to visualize the left adnexa. The ultrasound image that we'll obtain will look similar to the one above here to the right. Here we see an ovary with multiple cysts. Notice the screen indicator dot positioned towards the left of the screen, and notice the ovary is opposite to the screen indicator dot. Now, after fully visualizing the left adnexa, we'll need to go to step number 2 to visualize the right adnexa. We'll flip the probe 180 degrees, so now the marker is aimed towards the patient's left side. Move the probe towards the midline, identifying first the uterus, and then moving the probe into the right fornicele area. This way it will be adjacent to the cervix and will have a good view of the right adnexal structures. The ultrasound screen image that we'll obtain will show the ovary with a similar orientation to the first, as effectively we're flipping the probe 180 degrees to preserve the orientation on the screen. The next technique that can be very useful in ultrasounding the adnexal structures is known as the swing technique. In step number 1 of this technique, it's going to be exactly the same as in the flip technique. We'll position the probe with the probe marker towards the patient's right side, aiming the probe out towards the left adnexal structures to visualize the left ovary. The ultrasound image that we'll obtain will show the ovary opposite the screen indicator, as in the picture to the upper right. Now, step number 2, to visualize the other side, the right adnexal structures will be different than in the flip technique. For this maneuver, what we'll do is move the probe first to the midline to visualize the uterus, and then out towards the right adnexa to be positioned into the right fornicele area. We can visualize the right ovary by swinging the probe directly out to the right adnexal structures, but the ultrasound screen image that we'll obtain will show the ovary on the same side as the screen indicator, effectively in the opposite orientation as in the above image. So I think it's important for you to try both of these techniques and figure out which works better for you. There are some advantages of the individual techniques. The advantages of the flip technique is that it uses a slight curve in the endocavitary probe and aims it out towards the appropriate adnexal area to optimize the images on the ultrasound screen. The advantages of the swing technique is that there's no need to flip the probe 180 degrees while moving between the right versus left adnexal structures and visualizing the ovaries. Here are a couple other pearls for ultrasound of the adnexa. Remember first to have the patient completely void and have an empty bladder to best visualize the ovary, and use your non-dominant hand to push down on the abdominal wall, displacing bowel gas out of the way and sliding the ovary towards the probe to better investigate the ovary. Look for the ovary between the lateral aspect of the uterus, which should be medial on the screen, and the external iliac vessels laterally. Now let's watch a video on how to perform this exam. Let's review how to perform ultrasound of the adnexa. Notice that we're beginning in the short axis orientation with the probe marker over towards the patient's right side. We'll begin by visualizing the left adnexal structures, and notice we're advancing the probe into the left fornicele area adjacent to the cervix. We're using our non-dominant hand to displace bowel gas, and the ovary pops into view. Now we may have to move that probe up or down a little bit in a vertical axis to best orient towards the ovary. Now in the flip technique, we're going to rotate the probe 180, so now the probe marker is over towards the patient's left side, and advance the probe into the right adnexal area to best visualize the right ovary. So that's going to be called the flip technique, where we're flipping the probe 180 in between the two adnexal structures. The other technique is known as the swing technique. Here we're keeping the probe marker always over towards the right and just swinging the probe from first the left adnexa to now over towards the right adnexa as shown here. This just emphasizes the fact that we may need to move the probe up or down in a vertical axis to best visualize the ovary, as the ovary couldn't be in an anterior or posterior relation to the uterus. What are we looking for when we examine the adnexa for the ovaries? Well, the ovaries classically have, on ultrasound imaging, a chocolate chip cookie appearance due to the presence of small physiological cysts or follicular cysts. We may be able to visualize a larger cyst known as a corpus luteal cyst, a larger cyst that's seen in the later stages of the menstrual period or also in pregnancy. In pregnancy, the corpus luteum cyst will sustain the needed hormones for the pregnancy during the first 8 weeks and thus is a normal finding. However, ovarian cysts may be multiple and affect both ovaries, such as in a very commonly encountered condition, polycystic ovarian syndrome. Here's an ultrasound image showing a normal uterus and a normal ovary with small physiological cysts. We're scanning here in the short axis configuration, so the uterus is seen towards the midline. As we scan out to the lateral aspect, we can visualize another structure, which is the ovary. Notice that this ovary has multiple small, dark, or anechoic little cysts known as small follicular cysts. So I'm going to go ahead and still that image down, and again we see the uterus to the midline and the ovary with the follicular cysts just lateral. Now once we've identified the ovary lateral in the short axis configuration, rotate the probe so now the probe marker is towards the ceiling, and investigate the ovary in a second configuration to fully figure out the dimensions of the ovary. Here's another ovary in a short axis configuration, just lateral to the uterus. Again, I'm scanning out to the side, and there the ovary pops into view. Notice that this ovary has a different appearance than the last one that we saw. This ovary has a very large cyst, which is consistent with a corpus luteum cyst. So we see here some very important structures. The uterus is seen to the midline. Notice the external iliac artery and vein as seen lateral, setting up the lateral border of the pelvis. The ovary should be seen medial to the iliac artery and vein, which can be a very helpful landmark when we're looking to see the ovary. But again, this ovary has much larger cysts than in the last case, consistent with a corpus luteal cyst. Here's another ovary with multiple cysts. Again, we're scanning in a short axis configuration through the ovary, and notice the presence here of multiple small follicular cysts towards the outer periphery of the ovary. Now, to the rightward aspect of the ovary, we can see a larger cyst, which is consistent with a degenerating corpus luteum cyst. In this still image, we'll measure the outer boundaries of the ovary to accurately size the dimensions of the ovary. And we can see the calipers coming across as indicated by the A and B, measuring 3.18 centimeters and 2.93 centimeters in dimension, well within the normal dimensions of an ovary, which usually should be between 2 to 3 centimeters in dimensions. In this ovary, we notice a different appearance. Notice that we have two cystic areas, one hypoechoic or dark to the right, and one more solid area to the left. Interestingly enough, the solid area is consistent with an endometrioma, a commonly visualized type of ovarian cyst. But we can see here that this ovary has two very different appearing cystic structures within the interior portion, one more fluid-filled and one that appears more solid in nature, consistent with the probable endometrioma. In this next video clip, we have the appearance of an ovary that looks like a probable teratoma. The first thing we see is that this ovary is enlarged in its dimensions greater than 5 centimeters in its longest length. The next thing we notice is that it has a bivariate color appearance. To the left is brighter, and to the right is more hypoechoic or darker. And we recall that a teratoma is made up of many different types of fetal cell lines. We can actually have hair, teeth, and bone within the ovary. As we scan back and forth, we can actually see hyperechoic or bright areas consistent with probable teeth, the teeth of this ovary, if you will, but a probable teratoma on bedside sonography. In this video, we see an ovary with a very large cyst, and as we scan back and forth, we notice that the cyst has a hypoechoic or dark appearance in the interior of this ovary. Now remember, when we're measuring an ovary and a cyst, we want to first measure the internal dimensions of the ovarian cyst as shown as indicated by the marker A. Then we want to measure the total dimensions of the ovary as shown in marker B. But remember that the ovarian cyst is only going to be part of the ovary and that we should measure both the cyst and the total dimensions of the ovary as well. An advanced technique is to put Doppler flow on the ovary. Here we see a normal ovary with a couple cysts, and we're putting tune-away or color flow Doppler onto this ovary. And here we see a normal pattern of flow. Notice that we have pulsatile blood flow indicating ovarian artery flow to the ovary, well seen on bedside sonography. Now, ovarian torsion is one of those diagnoses that we may have to make in the emergency department, but Doppler flow can be a very advanced technique, one that's usually above the skills of most emergency physicians, and we'll go over how to best make the diagnosis of ovarian torsion in an upcoming module coming in sound bites. This video clip shows the fallopian tube filled with blood in a patient who had a ruptured ectopic pregnancy with a hematosalpinx. And what's interesting is that we see the serpiginous structure of the fallopian tube filled with fluid here off the back of the uterus in the cul-de-sac. Now normally the fallopian tube is not well visualized on bedside sonography, but as it fills with fluid, we can start to see it in its orientation with regard to the uterus. But this was actually a hematosalpinx or blood-filled tube in a patient who had a ruptured ectopic pregnancy. Now, another condition which can fill the tube with fluid is a tubulo-ovarian abscess. And what can happen is that as the patient develops a bad infection within the pelvis, the tube can fill up with pus, and again, fluid is going to appear dark or hypoechoic on bedside ultrasound. Here we see the classic appearance of a fluid-filled tube, or a pyosalpinx, a tube filled with pus, in a patient who unfortunately had a tubulo-ovarian abscess as a complication of pelvic inflammatory disease. So in conclusion, thanks for tuning in to part 2 of OBGYN ultrasound, focusing on the ultrasound of the adnexa. While this is definitely a more advanced ultrasound technique, it can provide very helpful information on the ovaries and adnexal structures that may be the etiology for your patient's pain. Now, the ovaries are mobile structures lateral to the uterus, and occasionally it can be difficult to find them on bedside ultrasound, so don't be frustrated if you don't find the ovaries every time. And as a general rule, don't forget that a formal ultrasound and consultation with OBGYN is indicated if you are considering ovarian torsion or another advanced diagnosis that affects the adnexal structures within the differential diagnosis for your patient. So I hope to see you next time as Soundbites continues.